Good evening, everyone. Welcome back to my YouTube channel. We are here to continue with our ECG Mastery series. This one is going to be part 2, but it's just a continuation of part 1. In part 1, what we finished, it was an introduction to ECG. We gave a definition and everything, types of leads, chest leads, or precordial leads, and then limb leads, unipolar and bipolar leads. We saw Wilson's central terminal to construct the unipolar leads, and then we saw how bipolar leads are placed. Then we only stopped on the Hex-axial limb system or lead system, but we didn't finish it because the augmented leads were not put, or the unipolar limb leads were not put. So today that's what we are going to do. But before we continue with this one, for you to understand this one, you must go and watch the first part 1 for the introductory part, for you to keep following. You have to follow. If you miss one part, it may be hard for you to understand unless you already advanced. But if you are just a beginner who needs basics, you have to watch part 1 and then continue to part 2, because what we did in part 1 I'm not repeating. If you enjoy this video, just remember to subscribe, hit the notification button or the bell icon for you to be notified whenever a new video is uploaded. As I told you, each weekend I'll be uploading a video. For this time I'm dealing with physiology and then with some clinical part, now ECG, because ECG is a very big topic. You cannot finish it early, but we shall go slowly by slowly until when we finish the physiology and then we start clinicals. So we are starting. Just as a reminder, just short reminder, we said here this one is lead 1, this one is lead 3, and then this one is lead 2. The positive pole is here, negative pole is here, the negative pole is here, the positive pole is here, positive pole is here, and then negative pole is here. We said all this one and we placed them here. This has lead 1, and then lead 2, and then lead 3. We did that one. And we gave them the angles at which they are acting. What we said, that anything going above this lead 1, this lead 1 is 0 degrees. Anything going up is negative, anything going down is positive. So from here to here we have a 60-degree angle. So lead 2 is at 60 degrees. And then lead 3, 90 is here. So 90 plus 30 is going to be 120. So lead 3 is at 120 degrees. These are positives. Yeah? Positive, positive. So here we have 180, and then going the other side, the other semicircle up, it is negative. So what was remaining is to put the augmented limb leads. Remember what we said, that here if you were to view the heart, these angles are not enough. For example, if we put the arteries this side, if we say that that is our heart, the arteries are here, these are in frontal plane, these are frontal plane. They're looking superiorly and inferiorly. So if inferiorly you have this lead 3 and lead 2, from 60 to 120 there is a difference of 60. So all this part is not seen. We don't know what is happening here. We don't know what is happening anywhere above this side, and also here we don't know. So for us to know what is really happening in this space, we give an example like that one of the camera. If you are in a hall, you want to record everything, you don't stand on one corner to record everything, otherwise the other extreme you won't get whatever is happening there. So if you want to capture everything that is happening in the hall full of people, you have to position cameras in different corners. Like one corner, if it's four corners, one camera in one corner, another camera, all 4 corners with cameras, and then even on the sides with cameras. You have to position cameras everywhere for you to capture the full event. Same applies here. For this only 3 leads, we are only seeing the inferior part and one part of the lateral part. whatever is happening from here going this side, we actually don't know. So that's why someone decided that we have to create more leads to see other parts of the heart, and those were augmented leads. Now we are going to put them here to complete the Hex-axial system. Here, as you see, the ones in the blue, they're going to be our augmented leads, and this one is going to be augmented IVF, AVF, and then this one is going to be augmented VL, and then this one is going to be augmented VR. So this, with these three, okay, the angles, this one is at positive 90 degrees, AVF, positive 90 degrees. This one is at negative 30 degrees from here, negative 30 degrees. And then this one, we are counting going the other side. So 90 plus, here this angle is 30, 90 plus 60 is going to be negative 150 degrees. Negative 150 degrees AVR is going to be at that angle. So with these 6 limb leads, we can see the heart from inferiorly. We see the heart from laterally with lead 1 and the AVL, and then we see the heart even from the right side with the AVR. So what we get from here, we see these 3 leads. We can group them, and these ones to be called inferior leads. These are inferior leads. They are neighbors or contiguous leads. So any change that happened in one of these should reflect in another one. If AVF is showing any abnormal change, that abnormal change should also be in lead 3 and or lead 2. It should be there. That's why we need to group them like this: inferior leads, lateral leads. These are high lateral, high lateral, lead 1 and AVL. They are high lateral leads or left lateral leads. And then this one is right. Yeah. So that is the Hex-axial system done. Why is it important? X Why is it important? It is important for determining the axis or electric axis, determining the electrical axis of the heart. Why do we need to know that? Okay, to determine the axis of the heart. Why? Because in many conditions that axis is going to be changed. For example, in congenital diseases, dextrocardia, or even to determine whether the leads were placed correctly, or even some other diseases like hypertrophies, or even in bundle branch blocks. We need to determine. So this one, it is important. So that was our point number 1, the Hex-axial lead system. So point number 2 We are going to go on precordial leads now. For chest leads, precordial leads or chest leads. So precordial leads, what are they? Precordial leads, we also said they are also unipolar leads. They are unipolar leads. They are named as from V1 to V6. They are 6. So what we are going to see, their placement and their orientation. We say the orientation is in the horizontal plane. Okay, horizontal. The horizontal plane, that's where the orientation is. So I'm just going to draw, and then we see. I'll show you. Yeah, this is our piece of a myocardium, and it is reflecting what? The RV, and then LV, and then this one is IV, yes, interventricular septum. This is LV, free wall, and this one is RV, free wall. And this one is the apex, we know. So this is the orientation of the precordial leads. There is a center which we named as Wilson's central terminal, which acts as the negative for these leads. And in this one, we said if it's a unipolar lead, or whenever the negative pole of a lead is hypothetical, or it was just constructed, formulated, it is named as V. So these ones are also named as V. V1, V2, V3, V4, V5, and V6. All these are the positive electrodes that are placed. These are exploring electrodes. Exploring electrodes, they are positive, and they are the ones placed on the chest wall. And this is how they see the heart. It sees the heart, it cuts the heart into the base, that is where the atria is, and then the ventricle. It cuts in the middle, not in the frontal plane. So the limb leads, they are showing from downwards, inferiorly, and then superiorly. But these ones, they are seeing anteriorly. That's why we only put them on the chest wall. Anteriorly, I'm going to show you the positioning. Anteriorly. And the negative is located here at the center. Wilson's central terminal is here. I'm assuming there's a positive here, a negative here, and all these ones, they are using this negative. Simple. And where we see, this one is seeing the free wall, RV free wall. This one is a bit septal, a bit of septal, and these ones, septal, anterior, these two, and then lateral. This is how they are labeled. This is lateral, anterior, lateral. Then this one you will find, depending on where you are reading from, this one is anterior, and then these ones can be regarded as septal, depending on where you get it from. So V1 and V2, they are seeing the septum. V4, V5, they're really seeing the anterior wall, and then V5, V6, they are seeing the lateral wall. We had from limb leads, we also had lateral leads, and those were AVL and the lead 1, but those were high lateral. So V5, V6, 1 and AVA, these are lateral leads. Anterior leads, they are V3, V4. Septal leads, V1, V2. Inferior leads, they are 2, 3 and AVF. That one is labeled. This is the orientation done. So now placement. Next. So this is the positioning. We said this they are going to be placed on a chest wall. So if you see the chest wall, this one is going to be the clavicles. These are the clavicles. And after the clavicle, we have the axillary, and we have the axilla. And this one is going to be the sternum. So this is the sternum. This is the xiphoid process. The xiphoid process of the sternum. And now we have the angle of Lewy here. Angle of Lewy. So we are going to count the intercostal spaces. Intercostal spaces, this is the space between the ribs. So if this is the first rib, second rib, third rib, fourth rib, fifth rib, sixth rib, like that. I've not finished everything. So intercostal spaces are counted: first intercostal space, second intercostal space, third intercostal space, fourth intercostal space, and then fifth intercostal space, then sixth, and so on and so forth downwards. So for V1, if we try to put in the heart here, our simple heart, we can put it that is our heart in blue. We have put inside here. This is the heart. So this point at fourth intercostal space at the right sternal border. Fourth intercostal space at the right sternal border. That is V1. V1 is going to be put fourth intercostal space at the right sternal border. And then V2 is also going to be put at fourth intercostal space at the left sternal border. Yeah. Now those are two. So this one is, if you have to label, this one is V1 and this one is V2. And then, yeah, before I continue, we have these three lines, these landmarks. We name them like this. This cuts the clavicle in the middle, or it cuts into the middle of the clavicle, and it's called mid clavicular line. This one, the first one. Then second one, it cuts at the start of the axilla. At the start of the axilla, but anteriorly. So it's called anterior axillary line. And then the other one, it cuts from the sides laterally, in the middle of the axilla. So it is called mid axillary line. When you're placing this one, these leads or these electrodes on the chest wall of the patient, you have to find these landmarks. You have to count the intercostal spaces. You have to locate the angle of Lewis, which is at the junction where the first rib and the first rib joins the sternum. Then below it we shall have the first intercostal space. You have to locate this one. Then you start from there, from the angle of Louis, then move with the fingers. 1, you find a bony prominence, you hear it, the second rib, you go below, no bone, then 2, and then 3, 4, 5, 6. You have to count it. You have to count it. Proper placement. If you don't place them well, then the ECG, whatever the waveforms, will not be correct, and then it will lead to wrong interpretation of the ECG. We don't want that one. Even when you're putting them, you have to locate these lines: anterior axillary line, parasternal, anterior or mid clavicular line. You have to locate the clavicle. Okay, this is the beginning of the clavicle. Where is its middle part? So the middle part is here. An imaginary line you draw and see where you have to place another electrode. So far V1 and V2 placed. So now next one, V3, we are going to skip it for now, and only we go for V4. V4 is put in the 5th intercostal space. This is the 4th, 5th intercostal space. 5th intercostal space in a or at a mid-clavicular line. 5th intercostal space, mid-clavicular line. And then V3 is put in between V4 and V2. So V3 in between V2 and V4. And then V5, 5th intercostal space at a anterior axillary line. And then V6, still 6 or 5th intercostal space and the mid axillary line. So this one is V6, V5, V4 and the V3, named like that. You see it? Is it clear? So we write the placement. V3 placed between V2 and V4, and then V4 placed in the 5th intercostal space at 5th intercostal space or in mid clavicular line, mid clavicular line. And then V5 is placed in the 5th intercostal space in anterior axillary line, anterior axillary line. And then V6 is put in like 5th or 6th intercostal space in mid axillary line, mid axillary line. So this is the placement of precordial leads. We have placed them. When you're having a patient, I think I'll record a video demonstrating how we actually place these ones here on the paper. It's just for answering exams. If they ask question comes, placement of precordial leads, you have to draw something like this and then write this. Simple. These are electrodes you place. So in the exam you have to draw something like this and then write this. You get marks. If you don't draw and you just write, you get a few marks, not all. you'll get some. If it's 5 marks, then you'll get like 2 only if you write. But if you draw, then you get everything. Yeah, we have finished placement, and then types we have finished. Now we are going for something a bit new. Yes, we are going for something new, but before going for that new thing, let's recap what we need to know. We need to know how leads are grouped. This is grouping. We have already said one of them. We have in groups, we have inferior leads, we have lateral leads, that is left, and then we have anterior leads, and then we have septal leads. If we say left lateral leads, and then we can say right lateral lead. And then which one are these ones? Again, we have already given them, but just to recap, this is so important. You must understand this one. If not, then many things will be difficult for you. We gave them at ZD2, 3, and AVF. Simple. The left lateral, we gave them as V5, V6, lead 1, and AVL. Simple. The anterior leads, we have said, depending on where you have read from, but it will be V3 and V4. Septal leads, still depending on where you've read from, it will be V1 and V2. And then right lateral is AVR. These are the groups. So this one is so important for what is coming next or in future topics. This grouping will be so important. The next thing is going to be sequence of cardiac stimulation. How is the heart actually stimulated? I've said this one so many times in physiology lectures. I've been saying this one, but now I'm repeating, because what is next if we start seeing the normal ECG? This one is so important in predicting the morphology of the waveforms that will be formed with the subsequent stimulation. Again, this one is so important. I've said this so many times in physiology classes, but I'm repeating it now because it is so important in predicting the morphology of the QRS complex that will be formed when we start the normal ECG. Not only for normal ECG, but in any pathologic state. It will help in predicting the sequence of cardiac stimulation. So we are going to go back to rewind and go back. We look at the photo we drew of the conduction system. If you didn't watch that video, please go back and look for action potential of physiology. In physiology, cardiac conduction system, you will see that photo and then you will read all the parts. For now, we are just going to see the sequence. We are not going to see anything else. We are just going back. And this is the photo of the cardiac conduction system. I'm not going to remind everything. We are just seeing that cardiac stimulation starts from the atria. Again, it starts from the atria. The SA node is located in the right atrium. So its location in the right atrium, the impulse generated will spread fast through the right atrium compared to the left atrium. Again, the part of the heart that is depolarized fast or that is stimulated fast is the atrium, or they are the atria. They have to be depolarized fast. But the depolarization in the atria, that one in the right atrium will be fast compared to the left atrium. So the right atrium first, left atrium next. The next is going to be the movement of the cardiac impulse through the AV node. And then bundle branches, or bundle of His, and then bundle branches. Now when it crosses the AV node, it starts running in the interventricular septum. This bundle of His runs through the interventricular septum. And then later divides into the left and the right and left bundle branches. But the left bundle branch gives a septal branch that depolarizes the septum. So for the ventricular side, the septum is taken as part of the ventricle. The septum will be depolarized first because this one has to continue going before it reaches the free walls. So before the impulse reaches the free walls of RV and then LV, the septum will have depolarized already. So ventricular depolarization happens in 3 stages. 3: septal depolarization, free wall depolarization, and then depolarization of the basal parts. What are the basal parts? The basal parts, they are the ones that is atrioventricular groove, or atrioventricular groove, and then this is free wall, ventricular free walls. So the basal parts, they are these ones that joins the artery. The basal parts, free walls, and then the basal parts. The depolarization happen like this, in that direction, and then this direction. Septal depolarization of the free wall, and then basal parts of the free walls depolarized last. Yeah, we've got the sequence: atrial depolarization, AV node, ventricular depolarization. But ventricular depolarization happens in 3 stages: septal depolarization of the free wall or free wall depolarization, and then basal depolarization of the basal parts of the free walls. Simple like that. Let's put it in writing, because you have to write this one. Put them in writing. So this is whatever we have said: that atrial depolarization first, but right atrium before the left atrium, and then AV conduction, that one we are not seeing. Ventricular depolarization happening in 3 phases: septal depolarization, free walls, and then the basal parts. The basal parts are these ones. Basal parts. So why the right atrium first? Because the source in a normal sinus rhythm, the source of the impulse is in the RA. So the right atrium depolarizes first if this is the SA node, and this one the AV node. It will happen in the RA first, then before it reaches this side. So on the P wave, on the ECG, the P wave, the first part, P wave indicates atrial depolarization. But since the right atrium depolarizes first before the LA, the first part is going to be for right atrium, and then the next part will be for left atrium. That is for P wave. And then ventricular depolarization. The ventricular depolarization happens in 3 stages. This is AV conduction again, the flat line, AV conduction, nothing is happening. The ventricular depolarization, the septal depolarization first, and it depolarizes from left to right. Again, depolarization of the septum, that is from left to right. Why left to right? Because the branch or the branch that depolarizes it is from the left bundle branch. Is from the left bundle branch. So the septal depolarization happens in this direction. From left to right, septal depolarization. So from left to right, it will be from left to right. Yeah, septal depolarization. Depending on the lead we are talking about, it will deflect another thing. So, but now, not the point now. And then free wall depolarization. Free wall depolarization is going to go this side. You see how these Purkinje fibers are radiating. So free wall will happen in this direction. Free walls. But because this one moves from the other side going upwards, the basal depolarization will happen in this direction. Because you see this one is going this side. So the Purkinje fibers are going upwards. So the bases are this side. So basal depolarization will be in this direction. Free walls, base, upwards. And then septal, left to right. Free wall depolarization in any direction. And then basal, upwards. So this is the basal depolarization. Free walls, we have the right free wall and then the left free wall. And then the apex. Clear? Now that is the sequence. That one is finished. Very simple, very easy. You have to get it. If you forget this, then the next part will also be very difficult for you. You have to understand this sequence of depolarizations. So now the next part, this one it's not new, but we are just building up. We did these things already. So we are just going to place the electrodes and then determine or predict the morphology of the waveform that is formed basing on this sequence of depolarization. And then maybe before we go to that, another thing I've just forgotten. We have, remember, we said when we were just beginning the first lecture, we saw that cardiac muscle has layers. We have this one, the epicardium. And then inside, the inside layer has a endocardium. So depolarization happens proceeds from endocardium to epicardium. That is the direction of depolarization. From endocardium to epicardium. Depolarization will only completes the cardiac cycle. No, we have repolarization. Whereas repolarization proceeds from proceeds epicardium to endocardium. The reason for this is a bit not advanced, but it is just in the direction of the action potential. It is just in the direction of the action potential. Why repolarization happens the other way? If endocardium depolarizes fast, or subendocardial layer depolarizes fast, and then towards the epicardium, that is the outside, then repolarization in actual sense or in essence should start from subendocardial layers also going outwards, because this one depolarizes fast, and then they should also repolarize next fast. Depolarize fast, repolarize fast, but that's not the case. You depolarize fast, you repolarize last. This is what happens in the heart. So depolarization happens in this direction, going outward. This is depolarization. But repolarization is in this direction. Why? Again, it's because the difference in the directions of the action potentials. I write because epicardial cells have a shorter action potential duration. Compared to subendocardial cells. Epicardial cells have the short action potential than compared to subendocardial cells. So what will happen? By the time the action potential of this one is still ongoing, the action potential of this one, epicardial layers, it is finished and they start repolarizing. Why? It is due to this is due to prolonged phase 2 in subendocardial cells compared to epicardial cells. The subendocardial cells have longer phase 2 of the action potential. We finished all those ones. If you are starting from this one and you are just a starter, first go back and watch the first lectures in physiology. It is shorter, it is longer compared to epicardial cells. So these ones will finish phase 2 and then start repolarizing before subendocardial cells. And that is why it will shift this side to the other side. Again, we said when an action potential or a depolarization waveform or a waveform of depolarization is moving towards a positive electrode of a lead, the depolarization will be, and then if it is moving away from a positive electrode of the lead, the depolarization or the waveform will be. We said all those ones, but we are going to recap next in the next video.